Well, I think that the new interventions and newer, I guess, in the last handful of years are really the backbone of most of my practice. So I think that when it comes to a condition like atopic dermatitis, for me, are more historical medications in the case of topical corticosteroids and even topical, calcineurin inhibitors are really just a bridge to get me to the therapies I want to now, as opposed to being the place where I just had to wait because I really didn't want to go to broader acting immunosuppressive medications. And so now I think about every patient as someone, how can I get them to the safest and most effective treatment choice that is highly targeted for the disease of interest in which I'm treating. And so, of course, the bevy of non-steroidal topical options that we've gotten in the last few years, in the case of tapinarof, ruxolitinib, and roflumilast, in the case of our oral medications like abrocitinib and upadacitinib, our biologic therapies, in the case of dupilumab and tralokinumab, lebrikizumab, and nemolizumab. And also very recently for an adjacent but similar disease state, chronic hand eczema, topical delgocitinib, we really have a richer toolbox than ever before and tools that can really treat almost every patient that walks into the door. The short answer is yes to all, but the slightly longer answer would be is I think that we have arrived at a point where I think we at least agree that atopic dermatitis is such a multidimensional condition that it's impossible to probably make one assessment of severity based on what you see with your eyeball and go forward with a treatment choice. Given that all of the options that I mentioned all have data backing their use, in terms of both efficacy, safety, sequencing is really going to be dependent a lot on what the patient tells you about their symptoms, what the patient maybe tells you about their comorbidities and disease course, what they prefer in terms of how they want to be treated, in addition to what you assess in terms of severity. And all of those things together help us build a pretty individual plan per patient. So often I get asked, what is the treatment that you use first with every patient? And there really isn't an answer to that question yet, because until the day comes about where there's a magic wand I can wave over my patient and say, this is the exact treatment for you, a lot of it is going to be based on that shared interaction. I think there's a broader recognition of atopic dermatitis as a systemic inflammatory condition, and thus it isn't a surprise that we expect many of our atopic comorbidities historically to share mechanisms of disease with these particular conditions. And so it's the reason why with some of our therapies, we've seen additional indications that treat multiple conditions. Some of our other therapies, we've seen positive data, but have not really approached additional indications. I think that, that's one way in which we are starting to try to parse out who's the right patient for the right treatment based on background comorbid assessment. And it's probably making us better physicians as well when we're thinking about some of those other conditions going on with our patients. I think that that's also one of the desires we have, though, in this world, too, knowing the heterogeneous comorbid manifestations of atopic dermatitis. What we would all like to see are clinical trials that take this into account and actually assess a few different things so we can maybe perhaps begin to clinically parse out our therapies even more. Yeah, so I think that there's been a couple of interesting developments over the last couple of years that bear mentioning. One, I'll state is a very this past year topic, chronic hand eczema, a disease state that really was not one that we understood or thought about that much in this country. In the course of our lecture, I spent a lot of time on this section talking about some of the updates in both prevalence, in the sense that we actually now have estimates of how common this disease is, maybe somewhere around 10% of the US population. We also understanding now about the severity, burden, and treatment choices historically patients have faced, how healthcare providers kind of feel about this information. And then also in terms of our therapies, we have our first approved therapy for chronic hand eczema, topical delgocitinib, a pan-JAK inhibitor. But even our existing atopic dermatitis therapies, many of them have engaged in hand-specific or hand-adjacent trials too. And so a lot of folks may not even be aware of the fact that we have a lot of data on this very particularly difficult to treat site. So I'd say that's one big area that we touch on that maybe is a little newer than previous years. I think that we spend a little time talking about some of our pediatric patients, and particularly how to approach the younger kiddos now that we have not only a systemic therapy approved for these younger ages, but also a few different topical therapies as well that move down. The most recent to move down to this younger age group was topical ruxolitinib, a topical kinase inhibitor. And so I'd say that's maybe the other update to pay attention to. And finally, a novel genetic test, really trying to allow individuals to maybe make a more informed choice between a biologic therapy versus oral JAK therapy. And so we spend a little time debating about exactly which is the right route to go and whether or not a test like that is helpful in the clinical world.